Good morning, respected faculty and dear colleagues. I'm Dr. Shivam, Senior Resident in Department of Neurology, AIMS, New Delhi, and I'm going to present a case today with multi-axial involvement. So we are going to discuss Mr. M, who is a 32-year-old male from Uttar Pradesh, shopkeeper by occupation. Patient has studied up to 10th standard and is a right-handed individual. Informant was a patient, his wife, and his father. So patient is symptomatic since he was 12 years of age. So we have a history spanning from around 20 years. Started with complaints of swaying while walking since past 20 years, followed by hearing difficulty since past 15 years, vision difficulty since past 10 years, and episodes of unprovoked fall since past 4 years. So the first symptom was swaying while walking since past 20 years, which was very gradual and in onset. And no medical care was also sought for next 10 years after these symptoms. But it was retrospective when they looked that patient was walking like a drunk person. He was missing targets while reaching for objects like a glass of water. And there was no increase in symptoms in dark, and there was no complaints of tendency to fall on one side. It was uh, he was more of the gait that they noticed that he was while walking. He was having some abnormal gait. 5 years into the illness, patient started complaining of hearing difficulty, which was equal involvement of both ears, again gradual and progressive. Patient started hearing television louder than the usual, and over time he developed difficulty in hearing on phone as well. Vision difficulty has been since past 10 years. It was gradual onset, painless loss of vision, simultaneous and equal involvement in both eyes. There was some recall bias as well, but at present, he can identify objects only up to 6 years. There was no color desaturation, there was no polyopia, and there's no worsening of vision in the night he has ever noticed during these 10 years. Besides that, patient since past 4 years now complains of episodes of unprovoked falls with a frequency of 1 to 2 per month. Patient had a sudden jerk and a fall forward while sitting or standing, with some episodes leading to trauma. And during these episodes, patient is unconscious for 3 to 5 seconds. And some of these episodes have been precipitated while eating or by loud noises, but there's no clear precipitant identified. There was no worsening of these symptoms on awakening or while going to sleep. There was no warning signs or symptoms prior to the episodes, and there was no associated tonic-clonic movements, tongue bite, or involuntary maturation. So these were the major four symptoms. Besides that, there's no history of headache, anosmias, diplopia, difficulty in getting up from squatting position, or sensory loss,
Move
or
to the next slide.
paresthesias, or bowel or bladder
Yeah.
involvement.
Okay. You can say the
So if you
positive
look at the
findings.
birth history of the patient, he is fourth in birth order out of the seven siblings he has. He was born out of a non-consanguineous marriage with normal developmental milestones. But as compared to other siblings, he has a poor scholastic performance. He dropped out at 10th standard, while his other siblings are graduated. Besides that, there's no history of there's a family history of psychiatric disturbances and facial dysmorphism in two of his paternal cousins, but they are not in touch with them. So, but they have there's a slide. There was some history on the paternal side of some psychiatric disturbances and facial
Okay, Shivam, go
dysmorphism.
back to the first slide. Just brief history analysis by Purushottam. First slide.
So
Yeah,
this
swaying. That next slide. That what do you say site of relation for the swaying in this patient?
patient presented.
No, don't read all thing. What do you think the
So
site of relation?
by this history, he is having this appendicular and axial ataxia, and there is no history of an increase in symptoms in dark, and no history of any observation phenomena. So it can be due to the involvement of cerebellar and
Okay, yeah. Suppose it is why not sensory ataxia?
it can be possibility, but we did not find any significant history of increase, any history of walking on a cotton wool like sensation.
No, that need not be there. See, what will the sensory in a sensory symptomatology in the posterior column involvement, large fiber involvement?
Sir, they have
They
symptoms.
can be positive at sensory. It may present only with a negative symptom. Negative symptom of large fiber is only ataxia.
Yes, sir.
They may not complain any positive symptom like paresthesia. If it is there, it is good. Otherwise, you can't totally say it is not sensory ataxia. So there are only two symptoms by which you can definitely say it is cerebellum. That is cerebellum,
Speech
dysarthria
and
and eye movement abnormality. These two will not occur with the posterior column or sensory ataxia.
Yes.
All other appendicular ataxia can all occur with severe proprioceptive loss.
Yes, sir.
So at this point, keep both the possibilities. Always
Yes,
in
sir.
analysis, keep both the possibility. After examination, you can clarify. So next slide. So here, keep the next slide. Hearing difficulty here louder than usual. Which situation produces a person here louder than usual?
Sir, sensory neural hearing loss, if it is there bilateral.
What situation patient hears louder than normal?
Uh, Ear television
If you work in the OPD, you will come across patients with that complaint very often in some other condition. There is no dampening, right? Which is the muscle causing dampening of the sound?
Okay, louder than usual.
Putting it, which other condition commonly you come across this particular complaint? Bell's palsy, no? Right? Due to weakness of stapedius muscle. Now, what is the next symptom? A patient is started speaking louder than usual. Which situation? Which type of deafness they speak louder than normal? Is it conductive deafness or a sensorineural deafness? Sensorineural deafness. Okay. Conductive deafness, they'll be comfortable in a noisy environment. Here they have to speak louder than normal. Look, go to the next slide now. So that shows bilateral sensorineural deafness is there. Then vision loss.
Vision loss for 10 years and...
No, don't read site of lesion.
So it can be a refractive error also because there is no history of any field defect.
Correct. Can be refractive error, perfectly right. It can be due to optic nerve involvement.
Can be optic atrophy or...
can be retinal disease. Or it can be even a cortical blindness. So all keep it. Only examination can disprove or prove. Okay, next slide. What do you think about that unprovoked falls? What is interpretation?
History of sudden jerk-like movement, so can be due to myoclonus, which is causing sudden
myoclonic.
unprovoked
There's
falls.
another statement given that loss of consciousness lasting for 3 to 5 seconds.
Myoclonic, then epilepsy.
Myoclonic epilepsy is okay. But do you think that myoclonus will get up immediate epilepsy by getting immediately? Is the loss of consciousness genuinely present or not? Or is it only a drop attack?
Sorry.
Was that history of loss of consciousness there or not?
Loss of consciousness was there.
There?
Some episodes had loss of consciousness, not all. But
not all.
Not all.
But that means can be see the other history. Some episodes are perceived with loud noise.
Stimulus sensitive, myoclonic can
it
be
could
stimulus
be
sensitive.
That point can favor this thing. What's the other condition which can precipitate for by loud noise or unexpected sound? Somebody calling from behind, so the patient suddenly drops down.
Reflex seizures.
Stimulus sensitive seizure, reflex epilepsy.
Yeah, that you already said, reflex epilepsy. That is a part of myoclonus producing that thing. Other cause of drop attack?
Hyperplexia.
So it can be
cataplexy. That can precipitate by sudden sound, hearing some sound or light. Somebody calling from behind, they collapse to the ground. So those they also kept in mind. The loss of consciousness in a myoclonic jerk should not ideally produce loss of consciousness lasting for 3 to 5 minutes. Anyway, I'm not sure about that thing. Maybe epilepsy. Okay, go to the next slide.
Besides, it can be generalized seizure also. So
yes. Okay. Then it's okay. But that is not given the history. Okay, some history-wise, what do you think? Just got progressive ataxia, cerebellar versus sensory, more likely cerebellar. Then hearing loss, visual difficulty, anti-visual pathway and all from history, you can't commit on that. Anyway, forget about the DD now. Okay, go to the examination. We'll reconfirm and then come back to the discussion.
So on examination, blood pressure was elevated, 170 by 90 mm of Hg. Pulse was 110 beats per minute regular. Patient has slightly triangular faces with short stature. There was alopecia, scephocephaly, exaggerated lumbar lordosis.
And go back to the first slide. What is the dysmorphism in this patient?
Some triangular faces was seen.
If I happen to see such a patient, I will take it as normal. The baldness and all, some people are also bald. Cataracts are also bald there.
Besides that, we can see alopecia there.
Okay, go to the next one.
There was caffeine macules. And then on higher mental function examination, patient lost 2 points in attention. Besides that, his speech was also, patient was having a scanning and an explosive speech.
Okay, that shows it's cerebellum. Correct.
Then on cranial nerves examination, visual acuity was 6 by 36 in both eyes with pinhole correction. And fundus, there was bilateral pale optic disc with distinct margins. Besides that, there was mild ptosis bilaterally with normal extraocular movements. Pupils were normal, and uh, air conduction was better than bone conduction in both ears, and Weber's was centralized. This was a motor examination. Only thing is, there was some weakness in hip flexion, which power by nearly 4 plus by 5, and ankle reflexes were bilaterally absent. On sensory examination, patient has decreased touch, pain, and temperature by 50% in both upper limbs and lower limbs. There was impaired vibration as well as proprioception up to bilateral knee vibration and proprioception up to bilateral angle, and rhombus was positive. Besides, in cerebellar examination, nose finger was impaired bilaterally. There was dysmetria, dysdiadokinesis. Heel shin test was impaired. Tandem was impaired, but there was no titubation, no rebound, or no nystagmus. This is a video of the patient.
So what do you think about the gait, Purushottam?
Sir, in this video, patient
Is normal.
normal.
We
appears
don't
to work
overinterpret.
normal.
See, since I got ataxia, don't say this is ataxic. You have to do tandem walking and all. Anyway, go to the next slide. Okay.
So what we have added was, like, after examination was some sensory involvement. Besides that, patient had some hypertension. And that was two things were added. So at these
So
point,
after examination, we found he has got a cerebellum is very definite because he has got staccato speech. He has got a peripheral neuropathy. He has got bilateral optic nerve involvement.
Optic
And
and optic atrophy was.
optic atrophy.
Okay,
and
right.
sensory hearing loss.
So these were the differentials which were considered at this stage, mostly mitochondrial disorders, including MRF, neuropathy, ataxia, retinitis pigmentosa, or MELAS or Polg related, and then other differential were storage disorders like Niemann-Pick's type C and GM1
why
ganglion.
not? Why did you consider SCA in this patient?
Sorry,
What is
sir?
the SCA? Spinocerebellar ataxia. His primary symptom is ataxia with added on optic nerve involvement and peripheral neuropathy. What is against SCA?
There's no long track no long track signs that we got.
Spinocerebellar ataxia.
Scars,
Scar 7 can be a possibility.
can be a possibility, but it can be a possibility.
Yeah, it's a possibility. We have to keep that as a first possibility, no? Because it's a starting symptom is
But
ataxia.
mostly they're autosomal dominant. Age of onset here was at 12 years. So that
So what? So what? That does not negate it. Can't SCA occur in younger age group?
can occur.
Yeah, keep that possibility. Then why not Friedreich's ataxia then?
Which ataxia?
Friedreich's ataxia.
Friedreich's ataxia, again, they can have peripheral neuropathy, but again, these hearing loss that is not commonly seen.
Which one?
Hearing loss, like sensory neural hearing
Oh,
loss,
they can have. If they can put his
and
hearing
then
loss.
optic atrophy,
Optic
and-
atrophy is uncommon. That part I agree.
and even scars can be a possibility. Friedreich's,
Okay. Mitochondrial, of course, agree with you. If there's a myoclonus is there, that's one strong possibility of mitochondrial cytopathy. So SCA, Friedreich's ataxia, then other possibility which you kept was what?
storage disorders, adult onset
Niemann-Pick disease is the presentation of Niemann-Pick disease. What is the tooth cardinal symptoms of Niemann-Pick disease?
they
In the eyes, what do you find? Eye signs. Purushottam?
They have vertical gaze.
Vertical
Vertical
gaze.
gaze.
And what is the movement disorder which commonly seen in this thing, Niemann-Pick? Dystonia. Other name itself is dystonic lipidosis. Here there is no dystonia at all, only cerebellar signs.
signs.
So I think that possibility becomes less likely. GM1 gangliosidosis, yes, so one can present like this. Okay, now to the next slide.
So these were the investigations. Serum lactate was elevated, 2.1 and Parkinson 2.6. Besides, the CSF lactate was normal. This was the NCS. So in motor NCS, CMAS were normal, but sensory NCS, all nerves were non-recordable.
He has also got deafness, you said, no? Deafness.
Deafness.
Why not Ruffsum disease?
Sorry?
Refsum's disease.
Refsum's, again, there was no evidence, or RP retinitis was optic atrophy, no
There
retinitis
the blindness
pigmentosa.
is due to RP, not due to optic atrophy. Here there's no RP. So otherwise
not.
that also is a possibility because it's a deafness also. Okay.
And myoclonus also can occur, but not very common. This was the pure tone audiometry, which is showing increased air conduction and bone conduction thresholds with no air-bone gap. This was the ECG of the patient, which is showing a short PR interval with a wide QRS complex and slurring QRS onset waveform, suggestive of a delta wave, which suggests a Wolff-Parkinson-White syndrome. So this was the EEG, though we could not record any myoclonus, but the background rhythm was normal, but there was occasionally generalized intermittent delta slowing with some showing a left centrotemporal onset. Again, somatosensory evoked potentials were normal. There are no giant giant somatosensory evoked potentials could be recorded. MRI brain was also normal. So we also went ahead with a left vastus lateralis muscle biopsy. So this is HNE staining showing maintained fascicular architecture with mild variation in size and numerous bluish fibers that were seen. In oxidative strains like COX with SDH, we are seeing a mosaic pattern here with some COX negative fibers staining up blue and the positive fibers staining up brown. So that is again in SDS stain, we are seeing blue racked fibers like we see red racked fibers. This is blue racked fibers we call in SDH stain. And this is a modified Gomori trichome stain where we see the classical irregularly intense red subsarcolemmal zones.
Shivam, you can sum up.
And the electron microscopy was classically showing parking lot pattern and zipper-like pattern of inclusions. Patient mitochondrial genetics were also positive for MRF with a high heteroplasmy. Patient was treated with mitochondrial cocktail along with amyloid.
Okay, thank you, Shivam. You all done very well. But what is the lesson you have learned from this our grand round? All three of you.
Analysis
the problem with all students is that they know the diagnosis. Okay, they try to create DD according to diagnosis. Not like that. You go symptom wise. Because another patient may come to you without any investigations, you have to make a diagnosis. Not all can afford genetic test, not all can afford MRI and electron microscopy. Since you're working in an institute, it's easy for you. For others, they're working in peripheral institute, they have to depend on the clinical diagnosis alone. Okay, Katrak sir will know that when we were studying, we had nothing in hand, nothing, not even a CT scan. So that thing you have to keep in mind. So go methodically, interpret the system, symptom-wise, findings-wise, then bring the then only you will learn. Who is the best teacher as far as you are concerned?
Patient.
Your own patient. So learn from the patient. So thank you, sir. Before concluding, I thank profusely Dr. Arun Garg for inviting me to for this podium, for this meeting. Every time he calls me also. Thank you, sir.